We're going to go into the nuts and bolts of treatment of glaucoma. We're going to have Dr. Monisha Vora, who is the glaucoma and cataract surgeon at the Kremer Eye Center here in Philadelphia. And she's going to talk about glaucoma medications I should know about. Monisha.
Good morning, everyone. Welcome to Philadelphia. We are so excited to have you. I was actually supposed to be up here about 5 minutes before my talk, but I was so smitten by the last talk, as I'm sure all of us were. It was just incredible. Kristen, thank you for your story. And it was so inspiring and really, makes me even think about, if I'm having my lowest days, how to really change and look through a thriving lens. So thank you for that. So I'm going to talk about something that's not as exciting, but I think it's still important because I think it's so relevant to everyone here. So we're going to talk about some medications. My colleague, Dr. Schaefer, is going to be talking a little bit more about the surgery. So we'll kind of start with medications and then move up forward. So glaucoma, as we all know, it's becoming more and more prevalent. So by the year 2030, about 70 million people are estimated to have glaucoma. About 50% of this increase is actually going to be seen in Asia and Africa. In Asia alone, 18 million people will have primary open-angle glaucoma, and 9 million will have primary angle closure glaucoma between the years of 2013 and 2040. In Africa, we will also see a very large increase in the prevalence of glaucoma. So glaucoma is here, and of course, we are all here to find better ways to treat it, to find better ways and strategies for improving the quality of life of our patients. And I'm going to start a little bit about talking about how we've taken care of glaucoma in the past, what we're doing today, and how we're going to be going forward in the future. So mostly the talk that I'm going to be presenting is about the medications that we use to treat glaucoma and how we can lower intraocular pressure with medicines alone. So 10 years ago, we kind of didn't have too many options available, or even more so, there were just a few medications available. And I'm going to kind of talk about a timeline of glaucoma medications. You may see some medications here that you are familiar with. Many of you are probably on some of these medications. And we'll talk about what we're seeing today. Right now, we have an explosion of medications and topical therapies available for the treatment of glaucoma, and where we're going, how glaucoma medications are evolving, how we are taking the medications out of the bottles and putting them into people's eyes directly. So it's very exciting in terms of what we are have available for the treatment of glaucoma. But let's start at the beginning. So glaucoma has many different ways of treating and lowering intraocular pressure. In the office, we can do a number of things. We can put people on drops. We can put medicines directly into their eyes, and we can also do laser therapies. And Dr. Schaefer is going to be talking a bit about that as well, so I won't cover that in this presentation. Let's go to eye anatomy. So anytime I am seeing patients in the office, I have a little model, and I show them the eye, and I say, okay, let's talk about what we're actually dealing with. So here's the eye. I'm sure many of you have seen this image or similar images online or in your doctor's offices. And I kind of want to focus on the very front portion of the eye. I'll see if I can put it right around there. And I'll put it on this side as well. So we're going to focus on the front portion of the eye, which is kind of where all the action is happening with these medications. So I kind of zoomed up a little bit, and I'm going to talk a little bit about the flow of fluid in the eye, just so we all know. So fluid is produced in the eye in a little structure back here called the ciliary body. You may have heard of this. Your doctor may have told you about this. And that fluid is produced in the ciliary body and essentially has to make its way from that middle portion of the eye towards the front of the eye at an area where the cornea, which is this front part here, the clear part of the eye, and the iris me, and that's called the trabecular meshwork. So the fluid is being formed in the ciliary body and eventually making its way to the trabecular meshwork. Now, when we talk about glaucoma medications and treatments, I oftentimes talk about a sink, and I often will tell patients, essentially, as a glaucoma surgeon, I am a plumber of your eye, and I'm going in there and trying to fix the various issues that may be happening, causing the water to essentially overflow. So if you look at a sink analogy, in a normal sink, you have the faucet at the top, and there's obviously water coming out of it. You have the sink, and then you have the drain at the bottom. Now, what can happen is in glaucoma, we can have issues with that outflow pathway. So either the sink is being clogged, the water is on, and it's going on without having much of a drainage pathway. And essentially what the glaucoma medications are trying to do are two things. One, either turning the faucet off or at least lowering the faucet's rate at which the fluid is coming out. So many of the medications that we'll talk about today will focus on kind of decreasing the flow of fluid from the eye or turning that faucet off. And the other way in which the glaucoma medications work is by opening up the drain. So by allowing the fluid to egress a little bit more easily from the eye. Now, this is just kind of an exhaustive list of the many classes of medications. We're going to be touching on all of these today. And I'll kind of start from where we started and then bring you guys to modern day treatments that we have available. So again, let's talk a little bit about the mechanics of how glaucoma medications work. So it's really all about plumbing in the eye, inflow and outflow. So whatever is being produced in the eye is producing a pressure. That's that pressure that your doctor is taking either with that little blue light or with a little pen or whatever it may be. And that number that they read off to you, 10, 15, 20, 30, even higher sometimes, that's the pressure that your eye has created by this fluid. Now, of course, you can't just keep producing fluid and not have an outflow pathway. And that's what we discussed earlier, where the trabecular meshwork sits. And that's where the fluid is egressing out of the eye. And there's a balance between the flow of the fluid that's in the eye with the fluid that's coming out. And if that fluid is appropriately regulated, then someone's pressure tends to be on the normal side. In glaucoma, we don't know everything about glaucoma. We're learning more and more every day, but we do know that there's a problem with the drain itself, and the drain is not working very effectively. So the medications essentially all try to target various aspects of this mechanism, either by suppressing the fluid. So we have medications here called aqueous suppressants. We'll talk about that. Those are medications that are turning that faucet off a little bit. And then we have other medications, like I mentioned, that go more towards the drain. They increase the trabecular outflow, the uveoscleral outflow, which is just another way for the fluid to leave the eye. So let's start at the beginning. Has anyone seen this medication, or is anyone still on this medication? Pilocarpine. Yeah, I agree. And it isn't one of our favorites, but it's still around and for good reason. So it is one of the first medications that's been used for glaucoma management. The mechanism of outflow, a mechanism of this medication is essentially it stretches open that drain. It allows more fluid to get drain out of the eye. So this really affects the drain. It works well, but there are many limitations, and I'm sure many of you have experienced these side effects. Headaches, decreased night vision, increased risk of retinal detachment. Some of these are just some of the side effects that we see with something like pilocarpine. It's not very convenient to dose. Many times it needs to be dosed multiple times a day, but coverage is really great and it's pretty cheap. It's been around for a very long time. So in certain patient populations, I myself as a glaucoma specialist still reach for pilocarpine. Of course, not all the time. We have many much improved options at this point in 2024, but this has been around for a long time. And I have many patients that maybe come in as a new patient to see me who are still on this medication. So it has its limitations, but it's very readily available. And that's why many people are still on it. So fast forward a little bit to about, the 1950s or so. This is when we had the development of carbonic anhydrase inhibitors. So pictured here is just a bottle of something called acetazolamide, or you may have heard of it named as Diamox. Has anyone ever had to take that before? Sure, yeah. This is a medication I reach for pretty readily, especially in patients who may need a lot of pressure reduction or we need to buy some time before surgery. It's been around for a very long time. And what this one does is rather than affecting the drain, it goes up to that faucet and tries to turn it off a little bit. Works very, very well, but lots of side effects as well. metallic taste, fatigue, tingling in the fingers, a little bit of numbness. And then, of course, if people are on it for long periods of time, it can really affect someone's blood chemistry panel. So this is something that we use while we're monitoring someone very closely. It needs to be dosed a couple of times a day as well to see an effect, but also great coverage. So you'll see as we talk about all of these medications, and this is kind of what I myself as a glaucoma specialist kind of think of every day, is there are certain medications that are better for certain people, and there are other medications that are better for other people. So our job really is to find the medication that's going to work best for the person that's sitting in our chair. So not everyone tolerates the medications easily. There are side effects, there are allergy concerns. Thankfully, we have just so many options available. It's really a matter of trial and error sometimes. Carbonic anhydrase inhibitors, if we go 40 years later from 1954 all the way up to 1994, it then became available as a drop. And so dorzolamide, acetazolamide, brinzolamide, these are some of the carbonic anhydrase inhibitors. Dorzolamide is probably the most common one that's seen on the market today. I'm sure there's a good number of people in this room that may be on that medication as well. It's the orange cap. So a lot of times your doctor may ask you, what drops are you on? And it's okay if you don't know all the names. Some of the names are very long and they can be confusing at times. But probably many of you know your cap colors. Are you on the orange one twice a day? Are you taking that teal one at nighttime? And even in our office alone, when we give out drop instructions for people, we oftentimes will put the name of the medication. We put the color right next to it, which oftentimes can really help in remembering some of these medications. So again, this is a carbonic anhydrase inhibitor. Works the same way, but now in just a drop form. It's least effective in terms of in comparison to all of the topical medications. We tend to reach for it more as maybe a third-line medication. Stinging, blurry vision, those are some of the most common side effects. Also not so convenient for dosing, at least 2 to 3 times a day to really have an effect, but great coverage. So you're seeing a theme here. The ones that aren't necessarily dosed, conveniently, have, maybe a higher side effect profile, tend to be cheaper and more readily available, and I'm sure we've all dealt with that many times. Great coverage for dorzolamide in particular. So you may be on that medication, your doctor may have put you on that. And it's a very reasonable medication, but we definitely have many more available and many more that are a little bit more effective. So who recognizes this medication? Yeah. So this is like the gold standard. Any of our trials in glaucoma and ophthalmology, or especially when a new medication comes out, they always compare it to timolol. So timolol is kind of like that gold standard medication. Kind of rewind back, it was available in 1978 for glaucoma treatment, and this one essentially decreases the production of fluid. So we have pilocarpine that gets the drain to work better. We have dorzolamide and timolol, which make the faucet run a little bit less. So this is what we call an aqueous suppressant. It works really, really well. So this is finally a medication that has their side effects, but works very, very well. Pretty convenient for dosing. You can even dose it once to twice a day. And even once a day, many patients are on it. Works very effectively. Usually dosed in the morning. But some of the big side effects that can limit the use of this medication are the systemic ones. So anyone that may have asthma, anyone that may have COPD, heart concerns, there are some medications out there, some beta blockers out there that we can use that are better for the heart than others. But this can limit some of the usage of this medication. And it has very good coverage, except for some specific beta blockers, especially like the ones I mentioned that may be better for the heart and lungs. So this is a medication, I saw a lot of hands grow up, and that's probably because it's so readily available. The coverage is so good, and overall, very well tolerated by most people. Moving on. Now, in 1998, we started getting smarter about some of the drops, and we started combining things because people were walking around with like multiple bottles of medication, and it just is an inconvenience. I know I can't even take a multivitamin once a day, so I don't know how I expect my patients to take 2 or 3 bottles of medications multiple times a day. And I think putting ourselves in the shoes of those who we are treating makes such a difference. And if we can, I try as much as I can to decrease that burden and that load for my patients, because every other visit they may come in that they forgot to take a drop. The compliance is an issue. There's just too many drops to take. So in 1998, some of those problems started to get better by combining some medications. So we have the first combination medication here, which is a combination of a beta blocker, so timolol, the yellow one that we saw, and a CAI, or carbonic anhydrase inhibitor, dorzolamide. So this is basically like taking two things and decreasing the faucet twice as well, you would think. It decreases the fluid production from the eye, works really well. So now we have two pretty good medications, timolol being very effective, dorzolamide also being as effective. And they are both trying to lower the pressure by decreasing the production of the fluid. The side effects are essentially class additive, so the side effects from beta blockers and the carbonic anhydrase inhibitors together. And it's dosed about two to three times a day. Overall, the generics have very good coverage. There are some versions of this medication, which you may have seen before, that comes in little vials. Those are the preservative-free versions, because if you remember, dorzolamide tends to cause a lot of stinging and burning, as do many of these medications. Any of the preservatives that are put into these medications to make them longer shelf life do cause irritations to the eye. And oftentimes, these are the reasons we have to stop these medications. So the preservative-free versions are also wonderful options, but they tend to be not as well covered. And definitely in the last 5 to 10 years, I've noticed it's becoming harder and harder to get some of the preservative-free versions for people. Prostaglandin analogs. So these are very, very popular. I'm sure all of you guys have heard of latanoprost, Lumigan, travoprost. There's many, many options. So these became available in 1996. And now we're going back to the drain, because essentially that's how they work. They increase the outflow of fluid using not really the conventional pathway of where the fluid goes, but kind of another pathway, what we call the uveoscleral pathway. They're very, very effective. They are very effective in lowering pressure. They're dosed once a day at night, so it's actually very convenient for most people. And some of the side effects are interesting. You can have iris color changes, so the colored part of the eye can permanently change. A nice side effect for many, many patients, especially our ladies here, they love those long lashes. So they get the long lashes effect. Even the guys come in with some of the most beautiful lashes I've ever seen. Thank you to the prostaglandin analogs. And do you remember when Brooke Shields was advertising for Latisse? Latisse was essentially a prostaglandin analog. And the coverage for the generics are quite good. The brand coverage tends to vary. So most patients probably nowadays are on something called latanoprost, but there's also many branded medications. So oftentimes we will switch to branded if we find that the generic just kind of isn't as effective anymore. And that's pretty common across all of the medications. Alpha agonists. So 1996, these were available for treatment, and they kind of work in a unique pathway in that they affect both the production of fluid as well as the egress of fluid from the eye. So very effective in lowering intraocular pressure. The biggest problem, though, with these medications is it has a very high allergy rate. Has anyone ever tried brimonidine, Alphagan, Combigan, and seen a really red eye? Yeah, I mean, maybe 15% right here. So it's very, very common to see. And even if you have a combination medication in which brimonidine is in there, oftentimes that's the culprit for the allergy. But that being said, this is a very effective medication. I have many patients who are on it, and oftentimes I'll see the allergy years later, which is always interesting that they've been on something for so long, and then all of a sudden, they tend to have this delayed onset reaction to it. It's dosed about 2 to 3 times a day. Good generic coverage as well, and then variable brand coverage, as you've probably seen. Another combination medication is a combination of a beta blocker and an alpha agonist. So the last combination we talked about was the yellow and the orange combined. This is basically a combination of the yellow and the purple, okay? So going back to those tops of colors, which you may be familiar with. It has that dual action of lowering the pressure, both from decreasing the production of the fluid. It's very, very effective, and same as goes with the other combination medication, class additive effects, typically dosed about 2 to 3 times a day. And same in terms of coverage, generics tend to be very easy to find, harder with some of the brand names. Some of these have also not, because they have gone generic over the last few years, so it's very hard sometimes to find even the brand names. Simbrinza. This is actually probably one of the newer combination drops or fixed dose combination, what we call it, FDCs. That was available in 2013, and it has the mechanism of action of both the orange tops, so the dorzolamide like medications, and the purple ones, the brimonidine ones. Very effective, similar to kind of what I've been mentioning in terms of class additive effects. Dosing about 2 to 3 times a day, variable coverage. And this is a great option if you can't tolerate a beta blocker. So any one of my patients that come in and they have asthma, and I usually, when I see people, I try to keep a running list called intolerances. And if they've tried a medication, I try to write down, what was the problem, so that it's very confusing over years, especially you're probably seeing your doctor for years and years at a time and you know each other. Your doctor, it's hard to remember all of this stuff. So it's good for you probably to keep a nice running list of, hey, I've tried this medication, this didn't work. It will help your doctor out greatly. Hopefully your doctor is probably keeping track of this as well, because we don't want to backtrack. We want to go forward and make your pressures better without subjecting you to medications that you previously have not tolerated. So in 2017, we had a kind of an interesting medication come out on the market. So this is essentially a combination of a prostaglandin analog, so latanoprostene, and then there's a medication on there, what we call a nitric oxide donator, Bunod. So it's latanoprostene Bunod, also known as Vyzulta. This was available in 2017, and this really helped increase the outflow of fluid from the eye. Definitely a bit more effective than latanoprost alone, same side effects or so as the prostaglandin analogs, and very conveniently dosed once at night. But as you've seen in this talk, the ones that are convenient and easy to take tend to be the most expensive. So this can be expensive at times depending on coverage. There is no generic for it. I oftentimes try to give as many samples of this as I can whenever possible. But this is a very effective drop, and it kind of goes back to the whole trying to make the quality of life better without having to put people on multiple drops multiple times a day. Anyone heard of this medication? Repressa. Yeah. So Repressa was also available about in 2017, and this is just an entirely different class. This is a medication essentially called a ROCK inhibitor, and what this does is it basically increases the flow of fluid out of the eye by opening up the drainage holes that are in the eye. So you have that trabecular meshwork of what we discussed. Sometimes the trabecular meshwork in glaucoma patients, it's very much difficult for the fluid to get through. It's almost like the fluid is trying to get through a large wall with no holes in it. And so what this medication does, it kind of creates this porosity to the trabecular meshwork, and it opens it up and allows these large beams of space that allow the fluid to essentially egress out of the eye. And so it increases the outflow by lowering also the downstream pressure. So this is actually one of the first medications that also affects the downstream pressure. So people often say, well, when the pressure is lowered, where does it go? Where does it go out of the eye? And people often want to know, where's the fluid coming? Is it leaking out of my eye? Where is it coming out? Well, it's not leaking out of the eye. What's happening is as the fluid is exiting the eye, it's essentially going towards the bloodstream, into the veins, and then eventually back to the heart. And so what this medication does, which none of the other medications have done it up until this point, is those blood vessels that the fluid is going to get dilated, and they get bigger, and they allow the fluid to kind of come to it a lot easier. So you have this kind of downstream effect. It's kind of like if you're in traffic and you have all these cars that are lined up, you really need to get those downstream cars to move out of the way for the traffic to flow. And that's essentially what is happening with this medication. The biggest problem is you can get red, sore, itchy eyes. They do tend to resolve, but some not entirely. It's dosed once at night. And again, it is a brand name, so there's no generic coverage at this time. And this is another version of it where we combined the Repressa, which is the notarsadale, with the prostaglandin analog. So you're kind of seeing the theme. We're trying to combine powerful medications into one to allow for that dual effect, that dual lowering pressure effect. This was available 2 years later in 2019. Also dosed once at night. There's no generic coverage for this as well. Coverage is improving for all of these medications, but can be quite variable. This one's a little bit newer. This is called Amlanti. It was approved in 2022. It's essentially what we call a selective prostaglandin EP2 receptor agonist. What does that mean? So an agonist essentially is something that goes to, it's like a protein that can kind of go and act like another protein. So prostaglandin analogs, essentially, when the prostaglandin is introduced to the eye, that molecule of the prostaglandin goes to the receptors, the little, kind of proteins in the drain of the eye, and make them work better. This is essentially something that's masquerading as a prostaglandin. It's an analog, and it kind of does the same thing. And it enhances the flow by pretending it's a prostaglandin analog. So the side effects actually are quite similar. It's dosed also once at night. And again, being so new, it is not covered by most insurances, and there's no generic. So a couple of things I want to just mention. If you guys have seen this, we do have a booth outside. So many patients will oftentimes say that it's very difficult to get the drops in because the drops fall over their face. They use 5 drops at one time. And those bottles are really, really small. You're paying $300 for this teeny little bottle, which is absurd, but it is what it is. And so what we now have readily available, which I actually have been using quite often in our office to prolong the bottle life, is something called a nanodropper. So it's essentially a drop delivery device. You can attach it to the end of the bottle, and it reduces that drop size. You can see it right there, by about 60%. So you can really increase the longevity of these bottles. There is a booth outside, so if you're interested in learning more about it, I oftentimes will have my patients order it themselves, and it can reduce the drop size. It can also reduce the side effect profile. The eye can't even hold the entire volume of a drop. It can actually hold 1/7 of it if you actually look at some of the academics behind it. But this is something that will kind of help decrease that drop size and, of course, prolong the length of your bottle and decrease your overall cost. So it's something I would definitely consider checking out if you can. And then there's also some interesting devices available. This is something called the Gentle Drop. It's a silicone device that's usually, it makes putting eye drops in a little easier, so you're not kind of fumbling with the drop. You can put the eye drop in this little silicone rest. It can rest right on the bridge of the nose. Fits over most bottle sizes, and essentially helps you improve your aim to allow the eye drops to get into your eye easily. Okay, so before we wrap up and go to more of the surgery and the laser aspect of glaucoma treatment, there's one other thing I wanted to talk about, and that's something called sustained release. So you may have seen sustained release before, but sustained release is essentially something where that's kind of the movement of glaucoma. We're trying to go towards more minimally invasive options, more sustained release options where we can take the compliance factor out of the equation. So many times people are coming in, they forgot their drops, they left their drops somewhere, they're not taking all the drop. And so the mindset of what we call interventional glaucoma is to go towards options where we can make it easier for you, where we can just put the medicine in your eye and then you don't have to worry about it. And that's kind of what we're talking about today. And there is one sustained release implant drug that's available currently on the market. I'm not sure if any of you have received this, but this is something called Durista. So essentially, it's a prostaglandin analog. It's called bimatoprost. It was approved in March of 2020, and it works just like a prostaglandin would, except without some of those side effects from preservatives. It's essentially a little pellet that we put directly into the front of the eye. This can be done in the office. And what it allows is the pressure to be regulated from a pellet versus you having to put the drops in every single day. So this is a wonderful option and a wonderful advancement for glaucoma medications and for the improvement of the quality of life of our patients. Now, of course, at this time, you can only have it done as a one-time administration. but the company, I think, is working to get more administrations approved because it is fairly new. And so it can have some out-of-pocket expenses with it. But there's great coverage. I've seen great coverage, especially in my Medicare patients for this. So if this is something that interests you, definitely talk to your doctor to see if you're a candidate for it. Now, that's basically all I had to say today. So I really thank you for your time. I hope this was informative. And if you have any questions at all, I'm readily available. I'm happy to talk to any of you. And please reach out to me if I could be of any help or any assistance. Thank you so much and have a good day. Thank you.